over the next few minutes, I'm going to sort of give you my thoughts on the craniocervical junction and specifically talk about odontoid fractures, and we'll do some of that in the lab and some very, this is a great setup because we can talk about this and do some hands-on things in the lab, which is going to be fabulous. So I'd like to start with the craniocervical junction, and as we talked about last night, and Jens brought this up, we're seeing more and more of this because of our first responders doing such a good job of being able to take these patients who in the past may have expired because of their significant craniocervical junction injury, but now they are surviving and getting to the hospital, and it is up to us to make sure that we take care of them appropriately. The problem with the craniocervical junction, though, is that this is stabilized mainly by ligamentous structures. And because of that, it's not like this horrific burst fracture that we see in the thoracolumbar junction where it's very obvious on radiographs, but it is less obvious and actually more subtle because of the ligamentous structures that are injured at the craniocervical junction. And I'd like to, for a minute, talk about these because this is going to be important, especially when we talk about odontoid fractures as well. The very strong alar ligaments that basically connect the tip of the odontoid to the occipital condyles. And because of this, because of these extremely strong ligaments, we need to think about occipit C1 and C2 as a complex. We can't just think of occipit and C1 and C1 and C2. We need to think about these structures because of their ligamentous attachments as one unit. Also, the transverse atlantal ligament is an extremely strong and important structure that basically the sling behind the odontoid attaching to the lateral masses of C1, and we talked about that in one of our cases yesterday. There's very significant importance of the transverse atlantal ligament. And again, the problem is we can't necessarily see this injury on radiographs, and so we need to imply this, and we'll talk about some of the means of looking at this. So there are all sorts of measurements that you can use that historically have been used to try to understand injury at the craniocervical junction. I think the two most important measurements were done by Harris. Actually, I was the beneficiary of Jack Harris, was the chairman of radiology when I was at Houston, University of Texas. And those of you may not know, but Jack Harris is the brother of Bill Harris, who is of obviously total joint fame. Most people don't know that, but they are brothers. And Jack Harris was passionate about cervical trauma, and he came up with sort of his rule of 12s. And I think it at least for a fast and quick look at determining whether or not significant craniocervical junction injury is present is important. And so he has two measurements. The first is Bayesian dental interval, where basically you take a point at the clivus and the tip of the odontoid, and that should be less than 12 millimeters. If it is more than 12 millimeters, there's likely an injury to the craniocervical junction. And also this Bayesian axial interval, where you take a line from the back of C2 and measure it to the clivus, and it should be less than 12 millimeters. The clivus should be less than 12 millimeters anterior to that line. If it is posterior to that line, that is abnormal as well. So these, in my opinion, are very good, at least initial evaluations of radiographs to determine whether or not there is significant injury at the craniocervical junction. And how we've taken care of these unstable injuries actually for me has been quite interesting over the last couple of decades. So when I was a resident, we had Bowman triple wires. So we kind of made plates out of bones and stuck wires, drilled holes in the bone plates. And then as I was finishing my residency, we had these Lukey wire rod constructs. The problem with these is they are axially unstable, and so the patient still needed to be placed in halos. And as Jens said, my trip, my fellowship to St. Gallen was really interesting for me, because this is really the first rigid stabilization of the occipitocervical junction. This was Fritz Magrel's concept, his construct, using basically AO reconstruction or third tubular plates, and then marrying that with a transarticular screw through the bottom of the plate. And this really allowed the first chance of truly stabilizing the occipitocervical junction. Now, obviously, there are a lot of issues and problems with putting screws through plates. Um, and for a while, we struggled with that until we came up, and this is something that I've had a passion over the last couple of decades, is junctional stabilization, occipital cervical and cervical thoracic stabilization. And now that we have these universal screw rod systems, at least for the young surgeons, you have no idea how difficult it was for us early on to treat these injuries and fix these fractures, because now with segmental fixation, where we're able to fix into the occiput, fix into C1, fix into C2 in all sorts of different ways, and we'll talk about those different fashions, fix into the lateral masses of the subaxial spine, and then transition that into the thoracic spine with pedicle fixation. This was extremely difficult, if not impossible, with our old plate screw constructs, and now it is very, very straightforward and very simple with our universal screw rod constructs, and we'll talk about that in just a moment, especially in the lab. But we've shown numerous times now that rigid stabilization of the occipitocervical junction is much better than our old non-rigid constructs, and mainly because of the complications of halos. We're going to talk about that a little bit more when we talk about odontoid fractures. But we've found that really when we put halos on patients, if we don't have rigid occipitocervical constructs, there's a lot of complications from the halo itself. So what I was able to do when I was with Magro is look up his initial series of using this first sort of rigid occipitocervical construct in 23 patients. He placed a transarticular screw in half of these patients, no halos. So none of these patients were placed in a halo. And universally, they all did well. We had one vertebral artery injury, and kind of we'll talk about, I think you saw last night, my last transarticular screw I ever put in my whole entire life. I think it's an elegant technique. I loved doing that operation. It's technically very, very precise, but probably, well, I don't think probably, without a doubt, the most dangerous screw that we as spine surgeons put in. But anyway, he had one vertebral artery injury from one of those screws, but a very, very high fusion rate. And really the first time that actually I was introduced to placing occipital screws and how strong these screws are. These are extremely strong screws, and if they're put in correctly, can provide very, very good fixation into the occiput. And numerous biomechanical studies have shown that really the strongest fixation in the occiput is with screws, much better than with hooks or wires, and 6 occipital screws lend the highest stiffness. And actually that was Magro's concept with his plates. He would put 3 screws through the plates in the occiput, and you'll see my technique is very close to this. So I'd just like to show you, there's all sorts of different ways of fixing into the occiput. Keel plates are very popular now, and a lot of people like this concept of a keel plate, but personally I find them very limiting. Actually less ability to place screws where they need to go. In what I learned from Magro, this sort of trajectory of placing 6 screws close to the midline but not in the midline. What happens when you put all your screws in the midline, you don't have as good torsional strength, but if you have them just off the midline, and actually with a rod construct that you'll see here, you bend the rod to the proper sagittal alignment of occipitocervical junction. This is key. This is critical. We don't have a lot of time to get into this, but this is probably the most important part of occipitocervical constructs, is making sure that the sagittal alignment is correct. I've seen one of the biggest problems, and especially when people first start doing this technique, is they don't put enough lordosis, and so the head basically is in a relative kyphosis, and the patients have all sorts of difficulty eating and even breathing and even functioning. The other problem is you put them in too much lordosis, their head is stuck up looking at the ceiling, which is a problem too. So it's critical to get the sagittal alignment exactly perfect. And then what the apex of these rods are usually down around C1, and then I allow them to, they usually either want to sort of bend out or bend in. I let them bend in close to, as they travel up to the midline, and then put these offset connectors, which allows this perfect positioning of these screws close to the midline, just off the midline in the very, very strong bone. This allows, again, 6 screws to be put in. The problem with keel plates, you usually can't get 6 screws in, maybe four at the most. But then with these offset connectors, allowing them to attach the rod. And you can put these screws pretty much anywhere, and these are the last screws that I put in. The problem with keel plates, you put the keel plate on first, and then everything has to go off the keel plate. But we've published this a number of times, this occipital construct, which is my preferred way to fixing the occiput. Now we're going to have a talk on C1 fractures, and I don't want to spend any time at all on that, other than, again, with C1 fractures, it's important to think about the ligamentous structures, because with transverse atlantal ligament disruption with these fractures, or significant Occipitocervical disruption that can occur with these C1 fractures, it's extremely important to realize that and understand it. Hangman's fracture is one of my favorite fractures. Fendi came up with a classification that still is in use today. Type 1 fractures less than 3 millimeters of displacement. Type 2 greater than 3 millimeters of displacement. Type 3 with an associated facet dislocation at C2, C3. Most of these injuries 70% are the type 1, very, very minimal displacement, and they do very well in simple collars. In fact, many studies show we don't have to even put these patients in halos. Up to a third of these are type 2 with more significant displacement, and many times they can be treated in a halo or a collar, except if there's significant C2, C3 disruption or spondylolisthesis, and then that needs to be addressed. And then low single digit incidence of these type 3 hangman's fractures with the facet dislocation. We had a nice discussion yesterday about trying to reduce facet dislocations, and these are unreducible because you could put as much traction as you want, but the body is not attached to the facet joints, and so these all have to have open reduction and internal fixation. An interesting subtype of these hangman's fractures, Starr and Eismont described, is this atypical hangman's fracture, where actually the fracture goes through the posterior body of C2, and it's really important to understand this type of fracture because of the significant increase in potential neurologic injury. Most of these fractures, like C1 burst fracture, Jefferson burst fractures, these hangman's fractures are expanding fractures, so the canal gets bigger, so there's less incidence of significant neurologic dysfunction. But in this type of fracture, where the fracture goes through the C2 body, that doesn't happen. It's not a neurologic expanding fracture, and so the incidence of neurologic injury is higher, and so that needs to be understood. For the rest of our time, we're going to talk about odontoid fractures, and this is what we're going to do in the lab. As Jens talked about yesterday, we're actually seeing so much more of this, and it's in a very difficult patient population in the elderly, and it's much different. Odontoid fractures in the elderly, much different than in the young patients, and specifically the type 2 odontoid fracture, which is most common. So when I was early in my career, most odontoid fractures I took care of were in the young patient, high energy risk takers, so more males than females. But nowadays, sort of this biphasic distribution, they are in elderly patients. They're low energy fractures, usually don't have other associated injuries, and an equal male to female ratio. We know that the non-union risk factors, very important that we understand this, and probably without a doubt, the most important factor in regards to a higher incidence of non-union is initial displacement of the fracture. And if there is more than 4 to 6 millimeters of initial displacement, the incidence of non-union is very, very high. Also, patients who are elderly, and as I get older, 50 years old does not seem to be so old, but it is old, and that's a risk factor. Posterior displacement, angulation, and especially delayed diagnosis. And in the older patient population, this is a big problem. Many times these patients are walking to the bathroom at night, don't want to wake their spouse up, trip on the rug, hit their head on the bathtub, and go back to bed, and they really don't know that they have a significant injury maybe a few days before it's actually diagnosed in the emergency room. Halo union rate. So we know that type 3 fractures actually do quite well in the halo, 95% chance that it will heal, but type 2 fractures less so. And actually this is the big problem, that patients don't do well even with halo treatment, the most rigid non-operative treatment. And especially patients who are elderly have a very, very difficult time healing these fractures, even in a halo. And the complications of placing elderly patients in a halo is extremely high. And some of the earlier studies showing a 21 times higher incidence of failure and complications in placing elderly patients in halos. Now, the most common problem with halos, pin site infections, big deal. That's not. We may even not even call that a complication. But in these elderly patients, pneumonia, death, respiratory decline is a big, big deal. And this is almost now a death sentence. We've seen many studies showing the significant, not just morbidity, but mortality of placing these elderly patients in halos. And Drew Bednar was one of the first guys that I know that actually showed this to us. This was shocking to me when I read his study. 42% incidence of in-hospital mortality. These patients died if they were older than 50 years old and treated non-operatively. And this has been subsequently shown in other studies showing this significant mortality rate of treating elderly patients with type 2 odontoid fractures non-operatively. And because of that, many people have recommended that patients be treated operatively, especially if they're elderly, to keep them out of halos. And some of the original studies showing posterior wiring constructs or anterior odontoid screws. And we'll talk about anterior odontoid screws in just a moment. But the treatment alternatives. So non-operative treatments, we have halo, probably the most rigid, well, without a doubt, the most rigid non-operative treatment, but that's a problem, especially in older patients. SOMI braces or 4 poster braces, and then what about hard collars or soft collars, and basically sort of homeopathic treatment of these odontoid fractures, and especially, and we can talk about this later, but maybe in older patients that are live in a nursing home, that may be a reasonable alternative. Operative treatment, the options are posterior wiring. All that's really fallen out of favor because we really need to put patients in halos if we use wiring constructs. Transarticular screws, either done posteriorly or anteriorly, which is an interesting technique. And then probably what more recently has been very popular is C1 lateral mass and then C2 pedicle or laminar screw construct, which is my favorite technique, or anterior odontoid screws. And especially in the right patient population, this is an elegant technique, a very, very nice technique. These patients, though, that are elderly, and Jens brought this up, these octogenarians who sustain these odontoid fractures. Many of them are not bedridden in a nursing home. Many of them are still functioning in society. And the complications of treating these patients is quite high. And this was one of the early studies looking at the difference of operative versus non-operative treatment. And you see in this study, actually a very high mortality rate in both groups, which is shocking, and a very high complication rate. The surgical group actually had more days in the hospital than the non-surgical group. But most of these patients, the mortality was from either putting them in a halo and having pulmonary complications or the postoperative pulmonary complications. Many studies have shown, again, the significant morbidity and mortality of placing these elderly patients in halos. And one of the sort of the definitive study, and our fearless leader, Dr. Chapman's name is on this study, looking at treatment of geriatric patients, type 2 odontoid fractures. I think this is probably the best study that has been done and probably will be done in a long time. This is a multi-center North American study of a very large number of patients, type 2 odontoid fractures treated surgically or non-surgically. Most of the surgical patients, 80% of them, had posterior C1, C2 fusions, and we'll talk about why that is. Especially in the elderly patients with odontoid screws having a tough time with the osteoporosis. And most of the non-operative patients were treated in a hard collar, again, because of the complications of placing them in halos. But the 12-month mortality rate was, in my opinion, still quite high, but the surgical group had a 50% lower incidence of mortality in that first year than the non-operative group. They had statistically better functional outcome measures measured by NDI and SF36, no difference in complications, and the non-union rate was statistically significantly less in the operative group compared to the non-operative group. This is probably one of the best studies, I think the best study, looking at type 2 odontoid fractures in the geriatric patients. Right, Jens? It's a good study. Too good. So there have been some guidelines, actually one of the best ones still, even though it's rather old now, looking at type 2 odontoid fractures, showed there's really insufficient evidence to support standards, but there are some guidelines. And their main guideline was that in patients older than 50 years old, they need to be considered for operative stabilization because of the complications of treating older patients non-operatively for type 2 odontoid fractures. Now let's talk about odontoid screws for the rest of our time here. But there have been many studies showing good results in older patients, but some showing not so good results in older patients, and mainly because of osteoporosis. The indications for anterior odontoid screw are acute type 2 or high type 3 fractures with a shallow base that may act like a type 2 fracture. They have to be reducible. We're going to talk about that in just a moment, why it's so important that we are able to reduce them before taking them into the operating room. In the old days, a concomitant C1 Jefferson burst fracture was a good reason for an anterior odontoid screw because with old wiring techniques, we couldn't fix into C1. But actually nowadays, with our ability to place screws in the lateral mass of C1, actually this is actually quite good. And Jens Chapman has shown quite nicely the ability to actually reduce these Jefferson fractures with posterior instrumentation. So this is not so much of an important factor to consider nowadays. Now, we need to understand the contraindications of anterior odontoid screws. If you can't reduce it, if you are unable to reduce this fracture, you can't even consider it. Non-acute, there's such a high incidence of failure of anterior odontoid screws with established non-unions that is definitely contraindication. And if there's a rupture of the transverse atlantal ligament, some studies showing up to 10% of patients with type 2 odontoid fractures will have a TAL rupture. And there have been some catastrophic neurologic declines because of this. And the problem is, again, if you're not looking for it, you likely will miss it because it's not obvious on radiographs. And that's why it's so important if you're going to put an anterior odontoid screw in. After you do that, you assess and make sure there's not C1, C2 instability because that can be catastrophic. And you see, even with MRI scans, although we can see these transverse atlantal ligament ruptures on MRI scans, it's not. There are some that are not obvious even on MRI scans. And this issue of osteoporosis is, at least in my opinion, what I've seen over the last few years, is a big contraindication or relative contraindication to anterior odontoid screw techniques. And oblique fractures that run in the same line as the screw, anterior inferior to posterior superior, I call this a relative contraindication because it's actually an elegant technique to put an anti-glide plate on. And actually I like doing that, but when you especially talk to neurosurgeons about anti-glide plates, their eyes get glassy. Right, Jens, they don't understand anti-glide plates. But this it's actually not that much of an indication, contraindication. The setup of this operation is really the whole operation. Actually, the technique of the operation, once you start, is not that big a deal. But setting this up is a big deal. And we're going to spend a little bit of time on that right now. So either 3-point head holder, or actually nowadays I actually use just a Gardner-Wells tongs because I've got more ability to actually move the head, and we'll talk about why that's important. But you absolutely have to be able to anatomically reduce this, and I make sure that I can reduce this fracture before taking them to the operating room. If I can't reduce it, then I'll tell them that they need a posterior C1, C2 fusion. But you have to be able to anatomically reduce this before you take them to the operating room. And you have to have perfect ability to see the fracture, see the odontoid, and especially sometimes the AP view is very difficult to see, and it's so important that you assess that and make sure that you can see that before you prep and drape. And you have to make sure that you can get your trajectory, that your hand can be in the proper position. This can be very, very difficult in certain types of fractures, especially in patients with big barrel chests. If you can't get your hand in the proper position, then you can't do this technique. And you should assess this before you prep and drape. And this is sort of the setup again, 2 C-arms. Sometimes a cork in the mouth is a good way to keep the mouth open, or a bunch of rolled 4x4s can keep the mouth open. And again, the ability to place the head in the proper position and actually either move the head up or down to make sure you can get your trajectory is very important, and this has to be assessed before you start this operation. You make the incision at the C5-6 level, then approach the C2, C3 disc space. Important to start in the very strong bone at the end plates, basically right inside the disc there, and exit the tip of the odontoid, which is the very, very strong bone where the alar ligaments have usually caused this bone to be very, very strong. place a 2.5 millimeter screw perfectly in the middle across the fracture, engaging the tip of the odontoid. As you see here, the strong bone that's at the end plate and also at the tip of the odontoid, you see how thick that bone is? That's where you want your screw start and end. And you see anterior where that blue arrow is, how thin it is anteriorly. And this is not the place to put the screw. You do not want to start the screw there. And I don't have the pointer here, but it's so important. Do you guys see that AP? You see the odontoid, perfect on an AP projection, and you see the lateral masses of C1, C2. You have to be able to see that. You cannot do this operation if you cannot see an AP. I can't tell you how many horrible x-rays I've seen with the screw being nowhere close, and because they weren't able to assess, especially the AP x-ray. So then I over-drill the body with a 3.5 millimeter drill to allow the screw to glide. We'll talk about sort of setting this up in a lag technique. Oh, there it is, thanks. And then tap the odontoid peg. And then the screw will slide through the gliding hole and then engage the odontoid tip. And then the last few threads, as you're placing the screw, as it engages the tip of the odontoid, will close the fracture. And this is the lag technique, a classic AO lag technique of fixing these fractures. Now, let's talk about some difficulties with this. It's so important to put this screw in the very strong bone that is right here. So you actually have to get into the C2, C3 disc space. One of the big problems and biggest failures I've seen is when the screw is started too anteriorly. It's easy to start the screw here. It's difficult to get it down. It's difficult to get it in the proper position. And this is a classic example of this. What the problem is when you start the screw too anterior, number one, you can't get the shot across the fracture, so you end up very shallow. And basically what happened is surgeon put the screw right through the fracture, as you see right here. And it's in very, very weak bone here in the anterior body of C2. And you can't get the trajectory that you need through there. So what's the difference between the lag screw, the technique, versus the screw itself? I don't like to use the term lag screw. Basically, it's a partially threaded screw that you use in sort of a lagged fashion. So it's fine to use the partially threaded screw as long as the whole screw can get into the odontoid fragment and allow this compression across the fracture. The problem is if you have very high fracture, you can't get all the threads through that, and I can tell you how many times I've had to actually cut screws off in order to get a partially threaded screw across this. And there are clearly some people who don't understand the use of partially threaded screws in a lag fashion. AO tech, they would be rolling in their graves, right, Jens, with this lag screw. This is not a lag technique at all. Yes. Other technique issues, K-wire versus, I do not use a K-wire, and actually Ron Affelbaum's a good friend of mine, advocated using K-wires until recently when he's seen the complications, the significant problems of using K-wires. One of the biggest problems using K-wire, the problem is people get the K-wire across, feel at ease now. Now I got the K-wire across, now the whole operation is easy. That's when you should start being nervous. Once the K-wires are across and you start drilling over the K-wire, one of the problems if you're not perfectly collinear over that K-wire, and many times it's difficult to get your hand in the proper position with the drill to be collinear over the K-wire, is that you have tension basically there. It causes a shear at the tip of the drill, and you can shear the K-wire off. And this can happen. It absolutely can happen. There are many, many case reports of this. And actually, that's not the worst thing that can happen. The worst thing that can happen, and unfortunately this happens as well, is it binds the K-wire, and as you drive the drill across, it drives the K-wire with you, and it goes into the brainstem. And unfortunately, this is why Ron Affelbaum has advocated against using K-wires, because this happens way too often. Now, what about using 1 versus 2 screws? I'm a 1 screw guy because of some biomechanical studies that we did a long time ago and also verified by others that 1 screw is just as good as 2 screws. You need to understand that it doesn't provide normal stability of the odontoid, about half of it of a native intact odontoid, but there is no difference between 1 and 2 screws, and there are many clinical studies showing that there's no difference. Although Affelbaum has also recently describe, especially in the elderly patients, maybe 2 screws will increase the incidence of healing. The problem with 2 screws, though, it's really difficult to get 2 screws perfectly across into the odontoid, and many times you have no room. And this is a case of alpha bombs, actually, where because of how small the odontoid many times is, you can't even get both screws to engage the tip of the odontoid, and when you don't get cortical fixation, you can see this one screw backing out. I'm going to show you the last case, why I'm less an advocate of anterior odontoid screw fixation in elderly patients. This is the case of mine. I thought I put a perfect screw across here. I was very happy with the lag technique I was able to get across here. And what happened over a very short period of time is that it failed. And it was because this lady was older, was osteoporotic, and despite what I thought was a perfectly placed odontoid screw, the problem is I can't necessarily always predict whether an elderly osteoporotic patient is going to be able to tolerate a anterior odontoid screw. And because of that, and also because I can't many times reduce these odontoid fractures, and if you can't reduce them, again, you can't do this technique. And sometimes you think you can get it reduced, you go to the operating room and find out you can't reduce it, and you have to do a different operation. So because of that, I know that if I do a C1, C2 fusion, I'm always able to get a reduction and a stabilization of this fracture. And so we'll talk for just a second on C1 lateral mass screws. With our universal polyaxial screw rod constructs now, we can fix into C1, and this lateral mass screw of C1 is a very, very strong screw. The problem is that many of us may not be used to placing a screw in the lateral mass of C1. We haven't, over the years, had a reason to do it. Although it's interesting, Mogrel, before he came up with his transarticular C1, C2 screw technique, put screws in this lateral mass of C1, but had no way of really fixing it to C2 other than using a wire. So he put a wire around the screw of C1 and around the spinous process of C2, but found that that was not very strong. But nowadays, with our instrumentation, we have use of a lateral C1 mass screw. The problem is mobilizing the C2 nerve and understanding the vertebral artery. That's the whole issue of placing these C1 lateral mass screws. But very, very strong bone, and hopefully we'll be able to do this in the lab later today. A very, very good place to place your anchor in C1. Sometimes this is a little bit of an issue here. This posterior arch of C1 may get into the way, so we need to remove this a little bit and allow our polyaxial head to sit there. But this is a very, very strong place to anchor a screw. And again, placing these polyaxial screws in C1, very, very good technique. Now, understanding the course of the vertebral artery is extremely important, especially in fixation of C1. Again, I told you the transarticular screw, in my opinion, the most dangerous screw we put in, and also with the PAR screw, which is basically just a short transarticular screw. The reason is it starts usually below where the vertebral artery goes from medial to lateral, right at the inferior articular process of C2. Whereas the pedicle screw starts usually above that, so you are less in danger of the vertebral artery. And the PAR screw goes straight ahead, and the pedicle screw goes away from the vertebral artery. Here's the C2 nerve root and the C1 lateral mass screw position. And this has been described many, many times. Very, very good technique of stabilizing C1, C2. More recently, though, I've gone from using pedicle screws to laminar screws because, again, they're just as strong biomechanically, and we don't have to worry about the vertebral artery with our pedicle screw may get close, and this was described by Wright a number of years ago. We've done many biomechanical and anatomic studies now on C2 laminar screws, and they are my favorite, and I'll show you why. Early on, I was not so sure of them, so I would use a hybrid construct with a laminar screw on one side and a pedicle screw on the other side. And after getting a few CT scans showing I was very happy with my pedicle screws, but you can be very, very close to the vertebral artery. Although I've not had a vertebral artery injury with my pedicle screws, this certainly can be an issue, but you can have an issue with laminar screws as well. And so it's important that you understand how to put these in, and hopefully we can do this in the lab later on. But this now is my favored construct for, especially in the elderly patients, type 2 odontoid fractures. lateral vas C1, laminar screw of C2. Thank you so much for your time and attention.